How important would you say it is to being a successful midwife, whether you're a CNM, a CPM, a CM? How essential to being successful and safe in your job do you think having a collaborative partnership with a physician is?
It's essential. It's essential. He has had 4 years of medical school. I've had 2 years of graduate education. He has had 4 years of residency. I have had my beginning years, and I'm still a new midwife. I've been a midwife for 2 years. I learn something from him every day. So, and it's essential. I mean, I've had times when I've been watching a strip thinking, "No, I just want that baby out." And he's like, there are risks to both decisions. It's okay to wait. And I've learned when it's okay to wait and when it's not okay to wait. And, as long as I know that he's on the other end of the phone, making decisions along with me, I feel most of the time I manage a labor independently. He never even comes into the mix, but I know that he's pulling that strip up every now and then at home just to take a look, make sure everything's okay, because he knows he's my backup. And if I need him, he's got to haul it out of the house and get here. So, but it's essential because birth is not predictable. And the reason I became a nurse midwife is I like knowing that I've got a surgeon and I've got an OR when I need them.
Can I ask you what, because your hospital's smaller, what does the transfer look like to get to another hospital from yours if there's a situation? I'm curious of how that works, because you're already in hospital or whatever,
Right.
to get to the hospital with the extra care that you guys might not have.
If anything is going on during the labor that looks like maybe this isn't going to look great, all of the nurses are trained in neonatal resuscitation. We're all NRP certified. I'm NRP certified. There's an ER physician that's ERC NRP certified, and there are respiratory therapists that are NRP certified. We also have a pediatrician on call. And if a baby's not looking great on the strip, I have the pediatrician come to the bedside. I have the respiratory therapist come to the bedside. Excuse me. Once the baby's out, goes to the warmer, the resuscitation efforts start. If they're not going well within the first 15 minutes, we're on the phone with the transport team from the level 3 hospital that is about 20-25 minutes away. And they basically come and they get there fast. It amazes me. With a little rolling NICU on wheels. They've got all kinds of equipment. They can even start cooling a baby if they need to. I've never seen it happen in this hospital because I've only worked here for 7 months now. But so far, I haven't seen a baby that we haven't lost a baby. Every baby that's been transferred, we also get reports from the NICU that we do transfers from, and we go over them in our OB committee meeting after the fact to find out how the baby's doing and what could have contributed to the transfer. Sometimes there's no way of knowing what contributed to the transfer. But I'm not aware of any baby who did not have a pre-existing condition that wasn't known about that has died, because we're able to support the baby until the transport team gets there. And when the transport team gets there, they stabilize the baby as much as possible before they transport. Now, the difficulty, they'll put in IVs and they'll intubate the baby and things like that. If we need to, we can intubate the baby at my hospital, but we don't have a ventilator. They've got a rolling ventilator from the NICU team.
One thing you just said, it just reminds me of something I heard from a good friend who's an OB at a major hospital in Oregon, and she's worked there for she's been an OB for like over 20 years. And she told me when she'd heard my story about how my daughter died, that she had never had a that died in the time between labor and like the first few hours, whatever that's called, perinatal, maybe, that had death during that time of a baby that didn't have a pre-existing condition. She had never seen it. She was like, we don't see those. You guys, they're all over the home birth community. We don't see those in hospitals. Healthy babies don't just die.
Right.
Like while you're in labor, we have teams, we have things, they don't die like that. And that struck me because I'm thinking she's seen thousands and thousands and thousands of births. And she's like floored by this, that,
And this should just could be my limited experience as a midwife, because like I say, I've been a midwife for 2 years. I've been a labor and delivery nurse since the dark ages. But the only thing that I can think of that maybe would contribute to that would be an infection of some sort. But if you're Group B positive and we know about it ahead of time, we treat you. If we don't know whether or not you're Group B positive, we treat you. If something pops up during labor, if the mother's temp is going up, or there are sometimes things that you can see on the monitor that make you think, yeah, maybe there's an infection going on, we'll treat you. You know, so the only thing that I can think of that might allow that to happen would if the baby had an infection of some sort that we didn't catch ahead of time. But this thing about, oh, the baby was fine 1 minute and then was born dead, that doesn't make a bit of sense to me.
Yeah. The reality of preventable deaths that nobody wants to talk about because they're not getting checked out at home and nobody's evaluating them and nobody's going over them. And that's why we're continuously seeing over decades or generations of women, of babies dying and things, complications happening to women because home birth is never evolving. It's not changing. It's not updating. They're not telling each other we need to do better. There's things that we could have done to prevent this. They're basically saying it's the natural order, and it's not the natural order anymore. We live in a different time period. This isn't the 1800s or something else. Like, we need to be like with the times. And unfortunately, that's
no. And in the United States, we don't have a consistent transport system for mothers that are laboring at home. My late husband was, his family's from Scotland and England. And even there, they're not having their babies at home as much anymore as they used to. But the families that are having their babies at home, they go to the clinic for their appointments. And at, I think like around 36 weeks or something like that, they get a home visit from the midwives. If the home checks out, then they get a certificate that they take back to the clinic for the next visit, and they get their birth kit. And then when they go into labor, the midwives may come out and check them out early in labor and just look like, okay, everything is fine, just carry on. And then when they're in active labor, there are two midwives, not a midwife and a midwife assistant, but two midwives there in the home assisting the mother during that birth. There's also an ambulance on hold. There's also an OR on hold and a hospital room on hold. And there's a physician that they're communicating with consistently all during active labor. So there's, if something is not looking right, they will transfer at the drop of a hat. I don't know what the statistics are. I think there can probably still be things that fall through the cracks, but it's a whole lot safer than what's going on in the United States, where we don't have something that is set up like that.
No blanket of hell, nothing like, there's nothing. We have nothing. They're not communicating. They're not anything. And you call the ambulance and an EMT has no idea what to do. And I've heard of situations from EMTs that literally babies coming and they're like holding the baby in going, I can't deliver your baby. Please just make it to the hospital.
Yeah,
please. And the mom's like, I have to push.
I didn't even know that. I had a patient come to the office not too long ago. She was one of these moms who just had these miserable prodromal labors, and she'd come to the hospital and we'd send her home, and she'd come back and we'd send her home. And finally she decided one night that I am not going into that hospital unless I know I'm in labor. So she came to the office one morning and she was in advanced labor. So we had to call a squad and take her to the nearest hospital. She couldn't go to where she wanted to give birth, where we deliver. But I went with her because the EMTs looked at us and said, can one of you midwives come with us? Because she has this baby in the, and they went, yeah, I'll go. And it made me a little bit nervous because I thought, what if this baby's not doing okay when it comes out? You've only got so much room to move in those trucks, And she got to the other hospital fine and delivered fine. But yeah, no, I did not realize that they did not know how to deliver a baby. They don't.
They can't even, I think a lot of them can't even administer like anything. I mean, they can do an IV. Some of them can give you certain types of drugs, but then some of them can't. Like it's very, very, very limited. And I actually had a little experience with going in an ambulance, and I was pregnant with my rainbow, and it was horrible. to be pregnant and I was not in labor, I cannot imagine being in labor going in an ambulance because you're like bumping and bumping. Like it's
Yeah.
a horrible experience. You're in this little tight thing. You're on this like little bed thing. Like it was horrible like that. And I was just in the vehicle. I literally was in the back of the ambulance just pregnant. And I was like, oh, I'm never like, nope. I hope I never have to do this. So I don't know how other people through active labor, but I've talked to a bunch of EMTs and they've all said the same, that they are not trained. They actually would prefer you not to have your baby. They'd actually prefer you to keep it in. And I have heard stories of guys saying that they literally were like holding the baby's head, like, do not push it. She's like, push. And I was like, but you can't tell a woman not to push if the baby's coming out. And they're like, but they just don't know that, you know? And it's normally a guy. So he's like, I don't know what this is like. I'm like, oh, it's very basic. Just get you to the hospital. So
I think something else that's worth mentioning, though, is that, and this is based off of what I experienced, is if you're dealing with a birth center or a midwife and you're delivering at their central location, you might be getting paramedics and an ambulance who have been called to that location over and over and over again. When the paramedics showed up for me when my son passed away, like it was insane. It was a scene from a movie. The door like flew open before it was even stopped. I ran on, and something that people don't realize is that when these people, they're trained in emergencies. They're trained in dealing with the worst of the worst. But the worst of the worst that you deal with when you're showing up on an emergency scene from a birth, it goes to a different level of emotions that most people who encounter that on a day where they're not expecting it, like they might be used to showing up at car accidents and gun violence, but then they show up to a room where a woman's bleeding with a blue baby next to her, and that gets to them in ways that other emergencies don't. So it also does impact the job performance that they're able to give you. I know when I was in the ambulance, they were so flustered before they even showed up that the guy in the ambulance just like started talking to me, and he was like, I'm going to be completely honest, my hands are shaking and we're going to be to the hospital before I can do anything to help you. So please just tell me how you're feeling. Tell me what hurts. Tell me this, tell me that, so that I can give the messages to the doctor as soon as possible. Yeah. But he was shaking because he knew from where the phone call was being made. So birth centers around the country that are dealing with these kinds of transfers, and midwives around the country, like there is a reputation that's starting to build up around some of these places that has an impact on the emergency response that people are getting.
So you're thinking, are they like, oh no, what do we do? We're getting a call from this place again. Is that what you think is happening?
I know that for me, it actually wound up being the best case scenario because the hospital heard the address that I was getting transferred to from, and it was like an immediate, I don't know what code they would have called, but it was like an immediate code blue, whatever. By the time it took 4 minutes, 7 minutes from the time the phone call was made to when I got to the hospital. And when my gurney like went through the doors, there was like 12 people already with like their surgical caps and gowns and everything on, running to the door. I was knocked out in surgery within 15 minutes of the emergency call being made. From the birth center? Yes. That's amazing. Oh yeah, I got the best case scenario that you can think of for a hospital transfer mid-birth, and my son still died. Yeah, that's amazing. But the paramedics were on top of it. The doctors were on top of it. He was just like anything that I can do to you is not going to be able to impact you and save you and save your baby before we get to the hospital. So, and he knew like what questions to ask me. When's the last time you felt the baby kick? How are your contractions? Are they regular? Are they this? Like he almost responded as somebody who was trained in labor and delivery because they get used to
So Madison, can I ask, I know it's a horrible memory to have, but what exactly was it that contributed to your son's death?
Well, it wound up being a cord compression.
Mm-hmm.
He rotated from one position to another position and pressed his cord. But to be completely honest, from the moment I was there for 16 hours, I pushed for 12. From the moment I walked in, I should have been transferred from the moment I got there. My heart rate was 139 when I got there. It was just a disaster. There was nothing in my care. And that's part of the problem that people need to realize, is that in charge of my care was a facility owned by a CNM. The first person who took my blood pressure when I first got there was a CNM. The rest of the time that I was there, I was with a CM and an RN who moonlights as a birth assistant at this place, but is an active employed nurse at a local hospital. So I was with like professionals, real professionals.
But I'm hearing you say you pushed for 12 hours. Oh my God.
Well, that's the trope in midwifery that bothers me the most, is when they say that it's the woman. Everything about birth is the woman. And everyone here has had pregnancies and childbirth. And you know, it really is you. It's your stamina. It's your this, it's your that, but it's also your doctor. It's your nurses who are overseeing your labor. It is your proximity to an OR and things like that that make it safe. And when I tell you that I could have pushed for another 12 hours and been fine. I could have. By the time the phone call was actually made to get the ambulance there, I was downstairs fully dressed from being fully naked on the 3rd floor down to the street within a minute. Like I at that point in time, but it was my adrenaline. And everything is based off of the woman in midwifery, that my adrenaline allowing me to continue pushing labor past what other women would have quit, that's the game they're playing. They want you to quit your labor before they have to pull the plug on it.
Standard of care for pushing is 4 hours for a first-time mother, 3 hours for a second-time mother. And let me tell you, after 2 hours, if we're not making any progress, I'm on the phone with my collaborator with a first-time mother. I'm like, watch with me for another hour. And if it's not happening, start making your way in, Yeah. And there have been times, well, one time so far, where, the mom just needed a little bit more steam, and he showed me a few coaching techniques. I thought I knew it all. And that baby was born at 4 hours, but he was in there coaching with me, helping to get her to push. I've got a second time mom, and 2 hours has gone by and that baby is just not coming down. He's going to come in and check this out too. And last time this happened, sure enough, you don't really see too many cases of true CPD anymore. This is a mother who had already had a baby before vaginally, but yep, she sure did, because I could not get that baby to come down. And it wasn't that she wasn't trying. That baby just was not going to fit. Which brings me back to two things that I hear so much in this community that make me want to just hurl. One is, you can't
read your mind here. Yeah. Right.
Make me lose my mind. Oh, yes, you can. Or babies know when to be born.
Right.
Ah,
Yep.
I just want to scream every time I hear that, because I'm like,
I hate those both. I hate both those myths.
I agree with you totally. So when I hear that somebody's been allowed to push for 12 hours, if something hasn't happened in 2 or 3 hours, it's not looking good. If it hasn't happened in 4 hours, it's not going to happen. Maybe the mother could do it, but she's getting more and more exhausted. What is the point? The worst outcomes with C-sections are after you've labored and pushed and then had a C-section, because it's not as controlled as it could be if you've got a planned C-section. Why are you going to go ahead and continue to push the envelope? It just makes me crazy.
So when it comes to VBACs, and anybody who comes in with you guys that is hoping to be a VBAC candidate, are there any people that you guys you risk out of your practice because you're like, maybe at a level 2 or level 3 NICU hospital, you would be a safe VBAC candidate, but at our lower level hospital, you wouldn't be?
I haven't seen that happen yet. I've seen a couple of situations where the mother very, very much wanted a VBAC, and we have done our best to discourage it. But I haven't seen us say, yeah, you can try it at a higher level hospital, because honestly, the hospital closest to us that has I think it's a level 3 NICU, they don't do VBACs. I'm not really sure what's behind that, but they don't do it. So I think that's another reason that we get a lot of VBAC business. There's a hospital one town over, the town that I live at, they've got a level 2 NICU. So they take babies as young as 32 weeks, and they will do VBACs at the hospital as well. But I haven't found myself in a situation yet that we've said, you'd be better off at another hospital doing a VBAC. I don't know if either of my partners have, or if my collaborator has, but it hasn't happened to me. And I haven't heard anything with my other partners or my collaborator recently where that's happened. We have been known to do VBACs after 2 C-sections. Those take a lot of deliberation by the OB committee, or the physicians on the OB committee that approve that. And I mean, I've sat in on these meetings and listened to their decision-making process. You know, this was what happened during her first labor. This is what her surgery consisted of. I agree with the management of that first labor. I think that this would be an appropriate risk. So, you know, they're doing their due diligence. And then, of course, there's the fact that we have a surgeon in the house. You know, and I've been in situations where, you know, we have your basic 30-minute decision to incision rule that every other hospital in Ohio does. And I come from a level 3 environment where we're used to thundering down the hall and getting babies out in 4 minutes. And that's what I'm accustomed to. So going to work in a smaller hospital gave me pause when it came to this. But having been mentored by physicians that have seen how well this works, knowing how to monitor a baby, knowing when you'd better not be counting on these reserves that these babies have. This is the time to go, or we've got time to wait. Learning the way that they manage these labors has taught me a lot. But there have been times where my collaborator has looked at me and said, you may have to first assist on this one. We've got anesthesia 24/7 at this hospital. And that's another thing that I think works in our favor, because we can put a woman under general anesthesia very quickly. But the surgery team may not be there. But each physician has a packet of their own instruments and tools that they, you know, their type of suture and their type of sharps and everything like that they use, gloves and everything like that, ready to go if we would have to run back for a C-section before the surgical team got there. And we just open the box of tools and he points and we hand. I've never had to do that yet, but it's happened before. So we basically have very similar capacity to a level 3 hospital as far as getting a woman back into surgery and getting the baby out. It's not as controlled as it is in a level 3 hospital, but so I think the key is that we have a surgeon on the floor and we have 24-hour anesthesia at this hospital. So did you have your baby in a birth center at home?
My child actually passed away in childbirth.
I'm so
and
sorry.
We were at a facility. The midwife calls it a birth center in social media, but it's not accredited. Mm-hmm. She is a CNM who exclusively works with out-of-hospital births, and she does not have an overseeing physician that she's associated with. So in New York State, she, up until COVID, was not legally allowed to be called a birth center. So it was basically just this house that was only a couple minutes from the nearest really good hospital. And I know when you have a baby, when your baby comes out of your body at her birth center, you get like however long until mother and baby are stable. And they do like the baby check, the mother check. They check you before you go home. And then they come within the first, it used to be 24 hours. I've heard it's now within the first 24 to 72.
That's crazy.
Hours.
That's the one in Buffalo, isn't it?
Yes.
Oh, okay.
Yeah.
Yeah. I am so sorry. I am so sorry.
Yeah, it's a disaster, but I'm kind of happy that it's happening as quickly as it is, because I think midwifery needs to see how bad they're allowing it to get.
Yeah.
That's true.
I don't
And
think
that's
they
happening
care.
here.
They
What's
haven't cared. I've been in
No,
this.
they don't. They don't.
They don't. I've been in this world now for 11 years. My daughter died 11 years ago, and nothing has changed.
Nope.
The same stories keep coming out, and the midwives act the same, and the same players are still there, and it's like I don't see anything changing. It makes me really sad.
You know, I have known a few direct entry midwives that really are good. They do transfer appropriately, they do monitor appropriately, but there's a tendency in the community to protect the ones that don't. And that's what I find is so frustrating. And in the community that I live in, I don't know all of them. I wish I did know them, because I feel like we need to be communicating, but they tend to keep themselves under wraps, even though I know that there are a lot, because with the Amish population, they tend to want to have, well, not all of them, but a lot of them want to have their babies at home. And there are midwives in this area that cater to that, both Amish and non-Amish. And the ones that are not making good decisions, they tend to be protected. And sometimes this protection comes from nurse midwives as well. Not so much in my area, but I know in some closed Facebook pages of other nurse midwives that I have been on, there's a lot of support for the direct entry midwives. There are some nurse midwives that do deliver at home, but they follow specific protocols. But they want there to be this, I don't know, sisterhood, I guess, for lack of a better word. You know, we don't want to get on their bad side. We don't want to give midwifery a bad name. And I'm like, it's getting a bad name because of this. I can't tell you how many times when I tell someone that I'm a nurse midwife, oh, you deliver babies at home. No, I don't. You know, they don't know the difference between a nurse midwife and a CPM or a just midwife. And
I actually had a friend have a baby about a week ago, and she and I have been friends since I was 7, she was 6. So I'm going to be 31 in a couple weeks. It's been a long time. And she just had her baby a week or so ago, and she wound up having a C-section because of failure to progress, and the baby wasn't handling labor well. And before the C-section, it was a nurse midwife in a hospital who was taking care of them. And because of what I just went through this year, her mother, because her mother's like a mother to me and knows what I went through.
Right.
And her mother was having a really hard time while she was in labor, being like, how is this happening? Where's your OB? We need a doctor, like this person. And it does, I think, a lot of my friends and family, I have to tell them now, no, like the Mercy midwives, they're good. Go to the Mercy midwives, just stick with the hospital.
Right.
Like that, the midwives aren't the designation of safety or being unsafe. The hospital, the facility, the location.
Right. And I know when I have a patient in labor, once I admit that patient, I let my collaborator know, hey, I've admitted this patient. This is where she's at in her labor. That's what my plan is for her. And he will pull her strip up at home, because we can get on our phones, our computers, whatever, and take a look at the fetal monitoring strip so that he can see what's going on. And then if I get into a situation during pushing or at any point during labor where I don't like what's going on, I'll either text him or call him myself, or tell one of the nurses to give him a text and say, make sure you're watching this strip because I may be calling you in. And I've had a couple of times where I've called him and said, can you just come in and sit at the desk, bring your coffee, and just be. And he'll do that for me, which is great. Because it is a small hospital. He is 20, 25 minutes away. And, babies have reserves. We know that we can get them through, a little bit of time before they totally tank, but we don't know how long that is. So I just want to know he's ready to go if we need him. And he's never failed me. 12 hours. I just want to scream. I am so sorry that you were put through that.
I know that I shouldn't just brush it off, but it's just the reality of midwifery. And I'm not unique. My story is not unique.
No,
There's
unfortunately,
aspects of it.
Not.
Exactly. And that's why it's important for all of us to be talking about it, because everyone here's story is different, but they all have the same elements.
Right.
One thing I do want to ask about, in your hospital, how often do you take in transfers from home birth midwives?
They happen occasionally. Usually if something is going really wrong, and it looks like the baby's going to need NICU care, they'll try to transfer to the level 3 hospital that has the NICU care. It hasn't happened too much since I've been there, but there have been transfers from time to time when a midwife didn't want to go to the big hospital. The big hospital doesn't have midwives. They are they're not a bad place at all. They're a good place. But the choices that we are perceived as providing a woman are not perceived, and I emphasize the word perceive or perception, as being available at this bigger hospital. So they're thinking that we're midwife friendly, because most of the vaginal deliveries at my hospital are done by nurse midwives. We're perceived as being midwife friendly, and they feel that they will be received better here and not chastised the way that they perceive they might be chastised if they transfer to the bigger hospital. If they come in an ambulance and we're closest to where they're coming from originally, they'll come to us. It doesn't seem to happen that often, though. There is a birth center that delivers mostly Amish. They have a nurse midwife, and they are overseen by a physician that also delivers at our hospital. We'll get transfers from there occasionally. Generally, it's for pain control. Rarely is it for risk factors that are not foreseen. I mean, it happens occasionally, but there has been, and this is only a story that I've told because I wasn't there when it happened. There has been once or twice a transfer that occurred from a home birth that should have gone to another hospital that had better, facilities for caring for a mother with that type of a risk factor. So like in my hospital, if a mother has features of severe preeclampsia and she needs magnesium sulfate run, we can't deliver them. We have to transfer them as long as they're stable enough to be transferred. There is a scope to our practice there too. But sometimes there has been a couple of cases where home birth midwives have transferred cases to us that were inappropriate for our hospital. The baby was under 35 weeks. The mother had severe preeclampsia. I don't know what they were specifically, but they transferred to us because they thought they were going to be better received. And then it places our physicians and our nurses in a very difficult situation in terms of liability, because we're simply not prepared to care for a woman with that risk factor. We have to get her delivered, call the transfer team from Akron or the big hospital east of us, and we send the mother to the ICU until the transfer team gets there for her, and all it does is delay her care.
Yeah.
And like I say, that hasn't happened since I've been there. I've heard of a couple of cases where that did happen in years gone by. We try to make it very clear to families who tell us that they want to have a home birth, what our expectations are, which is that if you want parallel care, you need to come to every prenatal visit. And that if something occurs during labor, we tell them, first of all, we feel that this is risky. It's not a risk worth taking. If you're dead set on doing this and you want parallel care, this is what our expectations are. And one of our expectations are, if something happens during your labor, you go to a hospital that can provide you with intensive care from the get-go. You don't transfer to us unless there's no other choice.
Yeah. I know that they do that here. Actually, we have a lot of hospitals where I'm at, and there's a lot of labor delivery, but they do try to go to, we have a couple more natural doctors that will kind of take the midwives, and they try to go to that doctor and that hospital, and, you know, they want to go to them. But the reality is I've talked to nurses and doctors from all the hospitals here in town, because I've become pretty well known, and they will take anybody. Like, if you're coming from a home birth situation, they just want you to get the care that you need. They just want to take care of your baby. They're not there to punish you or judge you. They really just want you to be safe and be
I don't
okay.
think that's
You know,
I don't think that's what's happening at the level 3 hospital that is east of us. I don't think that happens there. It's just that when they get there, they're going to be moving fast. They don't have time to be warm and fuzzy. They've got to get you stable, and they've got to get that baby out. We can worry about the warm fuzzies later. But there have been a couple of instances, I guess, where that hospital was closer, more appropriate, and they've gone right by that hospital, which makes me think about you every time, Danielle, and come to us because they feel like they're going to be received better. And we make it very clear. If the closest hospital is that hospital, then that's the hospital that you need to transfer to. We would prefer you just come to the hospital when you're in labor and not have to, do that. But there's, this community has a very strong bias towards home birth. And that's just something that we have to deal with.